Good afternoon and welcome to our Neuroscience lecture series. I am Dr. Gawad Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Luis Felipe Tornes. His presentation is titled Optimizing Epilepsy Management, the Role of Surgical Evaluation. Dr. Luis Felipe Tornes is a neurologist and director of epilepsy at Baptist Health Miami Neuroscience Institute. Dr. Tornes earned his medical degree from Florida International University, Harvard-Werdheim College of Medicine in Miami. He completed his neurology residency and a clinical neurophysiology fellowship at University of Miami Miller School of Medicine at Jackson Memorial Hospital Systems. He has presented at national conferences, and his field of his specialty is as a member of the American Academy of Neurology and American Epilepsy Society. As a neurologist, Dr. Tornes is deeply passionate about the profound impact his specialty can give to all his patients. Therefore, he is committed to the holistic care of the physical, emotional, and mental well-being of his patients and is dedicated to helping them to achieve and participate in their daily living and back in their communities, and also in their treatment plan. Please, let's give a warm welcome to Dr. Luis Felipe Tornes. Dr. Tornes, thank you so much for accepting our invitation. Welcome, and the floor is yours.
Thank you for having me, and thank you for that introduction. So let me go ahead here and share my screen. I also like to thank everyone for joining us today. So I'm going to be discussing today, basically optimizing epilepsy management and the role of surgical evaluation. We're going to be going over this, and just to start, before we get into it, I just want to say I have no disclosures. So just for the objectives and kind of what we're going to be talking about today, just to have an idea, we're going to be reviewing the epidemiology of epilepsy. We're going to be identifying the diagnostic criteria for drug-resistant epilepsy. We're going to be identifying appropriate patients for surgical evaluation and discuss diagnostic procedures in surgical evaluation. And then finally discuss the surgical interventions which are available for these patients. So starting off, the epilepsy epidemiology. This is more so for the United States in terms of the numbers, but in the United States, as of 2022, there was a population of around 331 million people. Out of that, around 1.2% of the population has epilepsy. So that comes to a little bit less than 4 million patients in the United States with epilepsy. Worldwide, there's around 50 million patients with epilepsy, according to the WHO. So that you can see there's a big percentage of the population around the world that has epilepsy. So it is something that's pretty commonly one of the more common neurological conditions that we see. So before we kind of dive into, even though this talk is about surgical evaluation, the surgical options, I wanted to touch quickly on medications, because this really is one of the first line and one of the options that we have for most of our patients. And I like this chart here because it kind of shows you the history of medications all the way from the 1800s, which you can see here with the first medication, which was bromide, and then all the new development in medications that we've had throughout the years. And you can see here there's a pretty extensive list, and this list doesn't even have everything that we currently have. It continues to grow. And even with all these medications, with all the advancements that we've made, we still have patients who are considered drug resistant, that they continue to have seizures even with these medications that are being used. So what exactly is drug-resistant epilepsy? And it's a term that I'll be using a lot throughout the discussion, so I just want to kind of clarify that. This is something that can also be referred to as refractory epilepsy or intractable epilepsy. The terms are interchangeable. But in 2010, the Task Force for the International League Against Epilepsy created a definition as a failure of adequate trial of 2 tolerated and appropriately chosen anti-seizure medications to achieve seizure freedom. So that's basically the definition that I will be using for drug-resistant epilepsy. So this chart right here, I'm sure some of you might have seen this before. It's a pretty well-known chart. It's from a study from Patrick Kahn and Martin Brody. And this basically shows you what the chance of obtaining seizure freedom is in patients with epilepsy when they're given medications. And you can see here on this side right here, when you start a patient on the first anti-seizure medication, they have around a 47% chance of obtaining seizure freedom. So it's almost a toss of a coin there if the patient's going to continue to have seizures. If you add a second medication, you're getting an additional 13% chance of having seizure freedom. So you still now are around 60% seizure freedom. If you add a third, it's 4%. So now 64% maybe seizure freedom. And every additional medication, the percent continues to drop. So that kind of leaves you around with 36% of the population's patients with epilepsy that are going to continue to have seizures, even with medications. And that comes out to, within the United States, 1.5 million patients with epilepsy that are considered drug resistant. And if worldwide, if you took that 36%, that would be around 18 million patients worldwide, which would have drug resistant epilepsy. So then what are the treatment options that we currently have for drug resistant epilepsy? So do we continue medications? Do we change medications? Do we add more medications if someone's coming in and they're already on 3 medications? Well, as you can see from that chart that I showed you on the previous slide, that the chances of you obtaining seizure freedom by continuing to add more medications beyond the third one, it's very low. So that's probably not your best choice, just because the percentages are very low. And you're also, with every medication you add, you're adding additional side effects from these medications. Do we make no changes whatsoever? That might sound like a crazy idea, but that's actually one that we see pretty frequently. If the person's on perhaps 3, maybe 4 medications, and they're not having that many frequent seizures, or the seizures are small, focal, unaware, or aware seizures, perhaps you decide that the patient doesn't really need to have anything else done, that they're well controlled enough. So that's another option that you sometimes see. Or the third option, which would be, is this person perhaps a candidate for surgical evaluation? So the prior chart that I showed you, that pie chart, hopefully kind of dissuaded you from continuing to add additional medications, knowing how small of a percent chance you have on really obtaining seizure freedom. And then the other one is basically what if we do nothing? Because perhaps the patient is only having a seizure here and there. It's not that bad. Well, even if the person's having infrequent seizures, there's still complications that arise from patients who have drug-resistant epilepsy and continue to have seizures. So in the United States, each year, around 1 in 1,000 out of 1,000 people with epilepsy will die from sudden unexplained death in epilepsy, SUDEP. And patients with uncontrolled epilepsy have a higher risk of death from complications secondary to epilepsy and suicide. Also, uncontrolled epilepsy leads to worse cognitive function, depression, anxiety, and a lower quality of life. So there are complications and basically risks that arise from having a patient continuing to have seizures. So it's something that really you should consider when making that decision of perhaps this patient's controlled well enough. There are complications that arise down the road from having them continue to have poorly controlled seizures. So it's something that you have to consider when you're making your decision. So then, keeping that all in mind, so what is the referral patterns then look like for patients with drug-resistant epilepsy? Are these people going to surgery, or what is it that most neurologists are doing? So I took this study here because it was actually a study that not only looked at neurologists, but epileptologists in particular. So these are patients with drug-resistant epilepsy who are being seen by an epileptologist. And out of 185 patients with drug-resistant epilepsy, only 43%, which was around 80, were recommended to a pre-surgical evaluation. Out of those, only 24 actually consented to the evaluation. 19 only went underwent the phase 1 evaluation, and then only 9 actually had completed the surgery. So you can see here that even amongst epileptologists, you're having a very small percentage of patients who are going in and actually having surgery. Even a small amount of them are even being discussed to have surgery. Less than half of them are even having the discussion of you should have surgery. So it isn't something as common as you would think. It is definitely something that appears to be under kind of recommended by neurologists, especially epileptologists. And overall, the mean time from surgery for adults from their first seizure to when they were having surgery was 20 years. So as you can see, it's also a very long time, even for those who are ending up going to surgery. It's taken a long time for them to get there. So why exactly is this then happening? What are the reasons that most people are not being referred to surgery? And this study here kind of looked at both reasons, both the patient and the epileptologist or the neurologist, why they're not referring them. And I do think that the keeping the patient's reasons in mind is very important, because obviously this isn't, you're not telling the patient what to do. It is something that you're working with the patient, and obviously you're not going to do something that the patient doesn't want. But I'd like to focus a little bit more on why the neurologists aren't the ones kind of recommending this, or why, from their perspective, are they not telling people to go ahead and get a surgical evaluation? And you can see here, the number one was low seizure frequency. And that's something that we already discussed, where yes, the person could be perhaps much better controlled on the 3 meds or the 2 meds that they were initially when you saw them, but there's still complications if they're still having seizures, and that's something you have to keep in mind. This isn't something where having infrequent seizures has no risk involved with it whatsoever. I know the second highest here is the basically a low assumed rate of success from the surgeries themselves. And that's something, obviously, surgeries have been around for a while, but they continue to advance and techniques continue to improve, and methods are changed. So what it was maybe a while ago is not really what it is nowadays. And people sometimes, when they kind of do their training or kind of what they were raised in terms of how they practice neurology, when changes come along, sometimes people are more hesitant to do these things, which is understandable, which is probably why that one's kind of high up there. And then the third is, again, low seizure severity, kind of similar to the first one. Maybe they're still having seizures, but they're focal aware seizures. So you're thinking, yeah, it's not that big a deal. They're not having any more generalized GTCs, or they're not secondarily generalization anymore. So why refer them to surgery when they're pretty well controlled? But again, there are complications and risks involved with having people continuing to have seizures. So kind of, since we talked about the risk of having the patients continue to have seizures, I just want to kind of discuss just broadly the success rate of the surgery, because that was the number 2 reason for why people weren't being referred for surgery, due to this assumed basically low success rate from having the surgeries. And in focal epilepsy attributed to temporal lobe etiology, resection has been shown to have rates of seizure freedom around 70%. So it is a pretty big percentage that you can see here in terms of seizure freedom from these patients who have temporal lobe epilepsy and getting resections. In focal epilepsy attributed to other etiologies, so those not necessarily temporal, the percentage is lower, and there are definitely certain areas where the risk, or the kind of the chances of you having seizure freedom are lower. Temporal lobe epilepsy is definitely the highest, and that's usually the best cases. But even for other cases, you're still seeing a 62% patients having a seizure freedom, which, as you can imagine, for a lot of these patients, that's a huge difference in their life, quality of life, if they're having seizure freedom, especially in these patients who are on multiple medications. So not only are they having seizures, but they're having complications from the side effects of the medications. So it is something that definitely can make a big impact in the patient's lives. So now, hopefully, I've convinced you that maybe referring these patients to surgery is a good option. So then the next step is exactly, how do you determine who's a good candidate for surgery? So in 2022, the International League Against Epilepsy created standards for basically what they thought were ideal candidates for surgical evaluation. And they basically said any patient with drug-resistant epilepsy up to the age of 70 should be referred for surgical evaluation. Any of the patients with drug-resistant epilepsy over the age of 70 that have low surgical risk should also be considered for surgery. And then the last one here is any patient, if they have seizure, basically, regardless of how many seizures they're having, they could be completely controlled on one medication, but they have a lesion, and they have a lesional epilepsy, and the lesion is a non-eloquent area, you should also be referring that person to surgery. Because even though they're seizure-free on one medication, if they have a lesion, removing that lesion could possibly have them be seizure-free without any medications whatsoever. And again, all medications have side effects, and a lot of patients would prefer to be on no medications if possible. So it's something that you should consider. So we've determined that we're going to send the patient for surgical evaluation. So basically, what exactly does that entail? What are we going to be doing for the patient? So the first part is called what we call phase 1 evaluation, and that's the non-invasive pre-surgical evaluation. And basically that entails multiple things. One of the things that's going to entail is going to be the long-term video EEG monitoring within the epilepsy monitoring unit, the EMU. And that's one of the cornerstones of the phase 1 evaluation, bringing in a patient into the EMU, connecting them to long-term video monitoring, and basically determining where their seizures coming from with scalp electrodes. So non-invasive monitoring. And in addition with this, there's a lot of neuroimaging that's involved as well. So MRIs, the brain, functional MRIs for perhaps language, determining language dominance, PET scans as well to see there's decreased uptake in certain areas. Also SPECT scans could also be done. And then in addition to neuroimaging, we also have neuropsychological testing as well that's needed. And then the WADA testing also can be still done for language and memory dominance as well. And then you can also see the magnetoencephalography, the MEG, which can also help you in determining the location from where the seizures are originating. So you can see it's pretty an extensive workup that's done, and it takes multiple different specialties involved, not only the neurologist, but there's neuropsychologists, neuroradiologists, neurosurgeons as well are involved. So it's something, it's a multidisciplinary approach to kind of doing this evaluation. So if you were, let's say we were to do this phase 1 evaluation, we're able to get a good amount of information. We determine perhaps the patient is a candidate following this phase 1 evaluation for surgery, but we still don't know exactly where the seizures are coming from. And if we're going to do a resection, we want to be very sure of what we're resecting, especially if it's a non-lesional case. Sometimes we refer patients to a phase 2 evaluation. And the phase 2 evaluation is the invasive pre-surgical evaluation. So not every candidate that undergoes a phase 1 evaluation for surgery necessarily needs a phase 2, but some of them do. And basically what this is doing is we're obtaining more information, because the scalp electrodes really can only get you so far in really localizing where the seizures are coming from. Sometimes you need to get a little bit more information, and that's kind of when we do the phase 2. Phase 2 is basically the intracranial EEG monitoring, and there's two options which you usually see. It's the subdural grids, which you can see here in the top right, and then the stereo EEG, which is the depth electrodes. So the grids, which you kind of see up here, were something that you saw a lot in the United States previously. That was kind of the most common thing we did here. And actually it was more so in Europe and in other countries where they were doing the depth electrodes, which you see here, the stereo EEG. And now we've started to kind of transition over to stereo EEG. And most of the centers here are starting to do stereo EEG really more so than the grids. They have multiple benefits. They both have their pros and cons. One of the big ones is it doesn't require a craniotomy. So it's not as invasive as a procedure for the patient. It's more comfortable for them. There's less side effects from also doing the depth electrodes, and the depth electrodes, as you can see in this kind of diagram down here, give you a better 3D representation of exactly where the seizures are coming from, and can help you pinpoint more so exactly where the origin of the seizure is, and exactly what areas should you be resecting in a surgery. So we've done the phase 1, we've done perhaps the phase 2 if that was necessary, and we have all the information that we need. So now we determine what exactly are the options we have available. What can we do for this patient? So on the left, you see the surgical options, which are the colostomy, the hemispherectomy, the lobectomy, the targeted resection or lesionectomy, or the laser ablation. So these are the ones that have been around for obviously longer. These are still the gold standard in terms of the basically surgery. If you're able to actually perform a lesionectomy, a laser ablation, or a lobectomy, that's going to guarantee you the biggest chance of seizure freedom on these patients. And that's what we tend to do if possible. But again, not every candidate, once you do the workup, is a candidate for surgery. Some might have multifocal epilepsy, so multiple locations. Some might be having seizures that are coming from eloquent cortex, which you cannot ablate. You're not going to resect that. And also sometimes people could have a generalized epilepsy, which isn't amenable to surgery either. So on the right here, you kind of see the other option, which is the neuromodulation options. And these are really a palliative option. These aren't going to give the patient seizure freedom, but they can have a pretty significant reduction in seizure quantity and their frequency. And this is one of the ones that I kind of want to focus a little bit more on, just because it is one of the newer things we're starting to see more and more now. Obviously, surgeries are still gold standard. They're still the best option if the patient's a candidate for them. But I think these are areas which are really having a lot of basically growth and research put into them, and are now giving patients that weren't possible candidates for surgery in the past new alternatives now for treatment, and it's really exciting. So the first one I wanted to just touch on was the responsive neurostimulation, so the RNS. So this was approved by the FDA in 2013 for patients with drug-resistant epilepsy with no more than 2 epileptogenic foci. And the reason for that is, as you can see here, basically the device is put intracranially, and it has 2 leads. It sits on top of this the cranium, not intracranially. And then it has 2 leads that basically go in to where the epileptic foci are. So that's why you can only have 2 foci. So if you have more than 2 foci, technically this isn't approved by the FDA. It's a closed loop system. And basically what that means is that the system is actually receiving feedback from the actual leads. And it's determining if the leads are picking up a seizure, the system then will send basically stimulation to the area. So it isn't one of those is kind of an open loop system is the other term we use, where there is no feedback whatsoever. You kind of set the parameters and it's constantly setting that stimulation for the parameters that were placed. This one's actually receiving feedback and is stimulating based on that feedback. So this was shown to have a 75% reduction in seizure frequency compared to baseline in 9 years. So that, again, it's not seizure freedom. This is a palliative option, but 75% seizure reduction is a huge amount for patients with seizures, and that can make a really big impact in their lives. It also showed better quality of life and improvement in cognition compared to baseline. Again, as we had mentioned earlier, there are risks of having patients continuing to have seizures, including poor cognition and quality of life. So it is something that helps. And there was a decrease in SUDEP seen when compared to a predefined competitor. So also another one of those complications that we mentioned, it could also decrease the amount of SUDEP that you can be seeing in patients. I'll quickly mention it. I didn't put it on the slide just because it's not necessarily FDA approved. But now as well, you're starting to see RNS devices not only put into the epileptic foci cortically, you're seeing leads be placed to the thalami as well. So you can put one lead cortically, you can put one lead into the thalamus, and you can change, it could be the anterior nucleus of the thalamus, the pulvinar, you can change the kind of the nuclei based on what your thought of where the seizures are coming from as well. And that's kind of something we're starting to see. So if someone's having, say, occipital lobe seizures, you might consider, and there's not a good like cortical foci for you to place the lead on. What you can do now is, or what you're starting to see now is people are, say, perhaps putting a lead into the pulvinar, thinking that the pulvinar nucleus is involved with the cortical seizures. So it's something that, again, it isn't FDA approved, but you're starting to see more and more of now within the use of RNS. So this is kind of just a chart that I discuss here in terms of the seizure reduction. So one of the things to keep in mind with the RNS is that there is actually increased reduction of seizures over time. So as you can see here from 3 to 9 years that there is increasing seizure reduction over time. So it is something that over time it does improve. And then this is just like a quick little idea of what the RNS looks like for the device. So as I said, there's 2 leads in the device, and those 2 leads have 4 contacts each. So in the top right here, you can kind of see this representation of an ECOG, and it's a 4-channel ECOG, which is what the device is giving you. So each of the leads has four contact points, and then basically this is being read in bipolar. It's a bipolar montage. So basically those 4 contacts are creating this here on those 2 leads. So you have the first 2 contacts, the more distal are seen in channel 1, and then the more proximal are seen in channel 2 on the first lead, and in the second lead, again, the more distal is channel 3, and then the more proximal are channel 4. And that's basically what's picking up the seizure detection. And then here on the bottom, this is kind of giving you an idea of the actual seizure frequency that the patient is having. It's almost like having a EEG connected to this patient that you're getting results from, which is one of the big benefits of this system, the RNS, having this kind of feedback of how many seizures is the patient having. You can see here when the device is initially implanted and the frequency of seizures. And this isn't to say that the seizures are getting worse, because initially when the device is implanted, it takes a little bit of time and tweaking before the device is able to accurately detect what are seizures. So then you start to see that it's starting to pick up seizures because it's now kind of detecting what the seizures are, and then stimulation is enabled, and then you can kind of track the flow and the improvement of seizures, not only from the actual RNS device itself, but as you can see here, optimization of therapy, that's also you managing the medications. So you adding a new medication, you increasing the dose of the medication that the patient's already on. You can actually get feedback from the RNS itself to determine, are these medications working? Are we getting a reduction in seizures? So that's another big benefit of this device that I think is very useful. And then the next device is the deep brain stimulation. So this one's been around in the world of neurology for a while in the movement specialty, but for epilepsy, it's been approved since 2018 by the FDA for use in focal epilepsy. So again, focal epilepsy, similar to what the RNS was. So this one specifically is, as you can see here, the device is implanted in the chest, and then there's a lead that goes to the anterior nucleus of the thalamus, and that's kind of the target. You can do it unilaterally or bilaterally in terms of the thalami, in terms of where you're implanting, and it's an open loop system. So kind of different from the RNS, where this one, you're putting in the parameters and the device is working based on those parameters. There isn't any feedback. You're not getting a live basically EEG, you're not seeing really how many seizures the patient having. The device isn't picking up seizures. It's not changing its output due to the amount of seizures. So it's an open loop system. And this one also showed around a 75% reduction in seizure frequency in 7 years. So again, a very big reduction in seizure frequency compared to basically no other alternative, or if not done. So again, this can make a pretty big impact in the patient's life, having a 75% seizure reduction. Again, it's palliative. This isn't seizure freedom. These patients aren't obtaining seizure freedom with this device. And similar to the RNS, I didn't put it on the slide because, again, it isn't FDA approved. You're starting to see some different targets as well in terms of the leads. Not all the leads now are being placed into the anterior nucleus of the thalamus. So that's something to keep in mind, that there is some more advances now in where the leads are being placed, and something that is changing. But FDA approved, it's only the anterior nucleus of the thalamus at this time. So this here, again, is a slide showing the improvement in terms of seizure frequency over time. Similar to the RNS, it's something that with time, you're getting more improvement in terms of the reduction in seizures. And up to seven years, you're seeing that 75% reduction. So it is something, keep in mind, both for the DBS, RNS, because a lot of times patients, if you do this, if they go through this whole workup, they go through the surgery, they get a neuromodulator. One of the neuromodulation options, be it DBS, RNS, or even VNS, they might feel it's not working as well. And it's something that you have to keep in mind and discuss with the patient. Well, there is going to be improvement over time. And most of the studies have shown that over time, you continue to have seizure frequency reduction. So it might not be optimal in the first year, but over time, it will continue to reduce their seizure frequency. So it's something you have to keep in mind and keep the patient, and make sure the patients are aware of it too, because sometimes they can become a little frustrated if they feel like they're not really seeing the results that they were expecting. So in summary, 36% of patients with epilepsy will have drug-resistant epilepsy. So that's a big chunk of your patient population that aren't going to be responding to medications. So it's something you always have to keep in mind when you're seeing someone that is coming in for epilepsy management, that you might not be able to control them with medications. And adding that third medication, as we saw in that chart, really is only giving you that 4% chance of getting seizure freedom. And every med you add after that, is the chances are lower and lower. So it's something you have to keep in mind, and obviously the side effects of the medication. So that's why we have these alternatives now that we can consider. So having these patients with drug-resistant epilepsy, I think it's really important to consider surgical evaluation earlier rather than later, because it is an option that gives the patients a really good chance of seizure freedom or seizure reduction with the neuromodulation. Complications from drug-resistant epilepsy exist, and there's higher morbidity and potential mortality with these patients if they continue to go on with poorly controlled seizures. So it's something that giving them this option with the surgeries is potentially can help them in terms of decreasing their mortality and morbidity. And there are a lot of new options now. Before, it used to really just be surgery. And there's a lot of patients that weren't candidates for surgery. But now with these neuromodulation options that have started to kind of come out now recently, with the RNS and the DBS and even VNS still being an option, there are new alternatives that weren't really there before, that now these patients perhaps even had a surgical workup in the past and they were deemed not a candidate. Now there's neuromodulation options available for them that could give them a pretty big reduction in their seizure frequency and really change their quality of life and make a big impact for them. So I think it's, even if someone's had a surgical evaluation before, but they never were considered for neuromodulation, it's something to consider now, because there are new options that are available for these patients. So these are my references, and that was it. Thank you so much.
Thank you so very much, Dr. Tornes. What a way of recapitulating the incredible amount of tools that you have at your disposal to treat this incredible disease. You mentioned in your opening that 1.2% of the total population in the U.S. Tend to be diagnosed or have suffered from or diagnosed with epilepsy. That's 4 million in the U.S. alone. That's quite a number. That is actually scary. And then a lot of things come to mind. Obviously, the old ways of actually treating epilepsy in the days was obviously with the first line of medications that you described initially, and we have come also a long way in actually identifying and treating accordingly to the needs of the patient. Not necessarily one treatment fits every single patient with epilepsy, and that is one of the approaches that we're taking today. Important to mention, as you already explained, that the drug-resistant epilepsy continues to be one of the biggest challenges you neurologists have in that particular population. As a matter of fact, you mentioned that 36% of these individuals that you have treated have manifested or manifest drug resistance. So the challenge is obviously for you as a neurologist, we assume, is now determining if the next path will be for a surgical evaluation. And I believe this is what we're all taking out of your lecture. Is that the case?
Yeah, so I think the biggest difficulty is really getting the patient into the evaluation itself. Obviously, there's limitations in the evaluation. As you kind of saw, it is pretty extensive. So it's something that not every center can do it. There's only a few centers that are able to provide the evaluation itself. And there's a lot of patients where they're just not either being referred, or even when patients within the centers themselves sometimes aren't being referred, because there's this idea of, well, the patient's not that poorly controlled, or there's a fear from the patient, so the patients don't really want to push for it. So you really have to have a good discussion with the patient and kind of tell them the benefits, and be an advocate for the patient themselves, because patients may be from a different doctor. And again, things have changed so much that perhaps years ago, because there are patients that have been with epilepsy for 40 plus years or more, and when they were, say, 50 years ago, they never really had these kind of options. Again, because not only surgeries were around, but kind of pinpointing where the seizures were coming from weren't really the same quality of what we have now. So the whole evaluation has changed, and us being able to really pinpoint where they're coming from and being able to do very specific resections and laser ablations and these options, that it's something that's really the biggest difficulty, is getting the patients into the door for the evaluation. And kind of, as you saw, it's a combination of both the patients sometimes being hesitant and the neurologists, not even neurologists, but epileptologists. So if you're having this hesitancy from epileptologists, imagine just your general neurologist or your general practitioner who's not a neurologist, which a lot of these sometimes underserved communities, you're having an epilepsy patient treated by a general practitioner. So for them, they might not know as much about these kind of surgeries. So it's something that we kind of have to continue to educate the population and kind of spread the word to get patients into for evaluation for these surgical cases.
Changing the culture, obviously, and the way we evaluate those patients that have already established a regimen to control epilepsy. As you clearly mentioned, some of these patients use it forever, and they say, well, this is the only option I have. It has worked for me. I haven't had a seizure in quite some time, but when you have it, then it is perhaps a little bit too late. And the other statistic that you mentioned is that 1 in 1,000, obviously, it's one is one too many, but 1 in 1,000 tend to die because of the DRE as a consequence. So that in itself should be, I guess, a point of underscoring the importance of reevaluating these patients, correct? That are already in the regimen.
Yeah, so it was 1 in 1,000 for SUDEP specifically, but patients with poorly controlled epilepsy and drug resistance actually have higher morbidity and mortality across the board. So not just from SUDEP, but also suicide as well. So it is something just for that alone, and just the quality of life metrics as well are lower for patients with epilepsy, cognitive impairments down the road. There's a lot of reasons why it's something you should consider, because even if they're having one seizure, it's rare. There's still complications that could arise from that and kind of worse outcomes down the road. So it is something you should always kind of still consider, because it's really common. You see patients that are on a regimen for many, many years, and they're kind of, from their perspective, like, oh, I'm okay. I don't have that many anymore. And there's always a hesitancy to kind of change anything. You don't want to rock the boat too much. But you have to kind of keep in the back of your mind that there are still complications and there are risks. And it's something that, again, not a lot of people discuss with their patients. It's something all neurologists, epileptologists as well. Sometimes it's hard to have these discussions with patients about SUDEP. It isn't something we really bring up too often with their patients. I'm sure most neurologists, if you were to ask them, how many of your epilepsy patients have you discussed SUDEP with? Do they even know what SUDEP is? You see, it's something that kind of just changing that culture and the education for the patients. Because obviously patients are hesitant. And you saw there on that graph I showed, patients, a lot of times you tell them, oh, we're going to do resect a portion of your brain. They take, whoa, that sounds crazy. I'm not going to do that. I'm only having one seizure a month. Like, why are we going to do that? So
radical.
Yeah, so it's something you got to really have a good discussion with, and you have to be really an advocate for your patient and really educate them on kind of the risks involved with not treating them, and basically the potential benefits of treating it.
Yeah, and that is such an important point you're making, because I believe that the strategy has always been, oh, we identified this kind of a foci, this kind of an epilepsy that you're suffering from. I'm going to recommend this particular regimen, and you're going to be on it. Let's visit once in a while, but we do not take the time to actually talk about the stages in which the individual is going to develop from the moment that had that initial seizure or epileptic episode, and then what potentially you can offer as a neurologist or neurosurgeon to alleviate that particular ailment in the future. That perhaps is the conundrum here, that we need to go back to the basics and discuss the current option, which is a phenomenal one to start maybe with a pill, but that there are alternatives if this continues to evolve.
Yeah, it's just one of those where you just got to kind of change your view on it, because more and more options are being now available, and there's always hesitancy. If you've always done something one way, it's always sometimes hard to change. Yeah. And if the patients a lot of times patients are happy with kind of how they're being treated. They don't really want to do too much. But even you got to consider, even outside of the kind of the risks in terms of morbidity and mortality and cognitive, it is a really big impact. Obviously, all the laws are a little bit different where you go, but in the United States and in Florida in particular, if you were to just have one seizure, say you have one seizure a year, you can't drive for 6 months after that. So that can make a huge impact in someone's life if they can't get around, and all the kind of precautions they have to take. And even just having one seizure, if you're driving when you're having your one seizure, that you could kill yourself and other people. So even having just one a year, it still has its risk. So it is something that
Thank you for highlighting that, Dr. Tornes, because that is such an important thing to consider, that an individual with epilepsy, especially if they are recurrent seizures, they will be disabled. So that would not only put him or herself at risk, but others. What an incredible portion of the conversation. The other thing I wanted to highlight, and just to recapitulate, is the fact that obviously surgery continues to be the gold standard that you have in your armamentarium as one of the treatments or treatment options. And you listed a long list of different type from colostomy to hemispherectomy to lobectomy. Which one of these are the most common that you see in your practice or that you actually perform?
So the more common ones, in terms of if the patient is actually a candidate for surgery, I would say are the lesionectomies, the lobectomies, and the laser ablation. So obviously you want to try to remove as little as possible of the brain. So you really want to get just the area which is basically where the epileptic foci is, where the seizures are coming from. So if you can basically do that with a laser ablation or a lesionectomy, that's ideal, because you're basically doing the least amount of damage to the surrounding area. You're just taking away the portion of the brain that's just epileptogenic, and you're kind of preventing any cognitive or any secondary side effects from these surgeries, because the surgeries as well do have their risk, and they do have sometimes complications. So the more minimal, the better. And laser ablation, really, it's pretty crazy. It's not that new. It's been around now for probably around 10 years, maybe like a little more. But just had a minimally invasive surgery, where basically almost like a tiny little pinhole through the back of the skull. They kind of go in, ablate the area, especially for the ideal ones are always the mesiotemporal lobe sclerosis, the temporal lobe epilepsy. You go in, you ablate the mesiotemporal sclerosis, and the next day the patient's out of surgery. They're going home, basically. They're out of surgery. They go to kind of stay in the hospital for one day, and then the next day they're going home. So it's kind of crazy, and that can almost get the patient to 70% seizure freedom. That's a huge change in their quality of life on a minimally invasive surgery. Obviously, not everyone's a candidate for laser ablation. Sometimes you do have to do a lobectomy or a lesionectomy. Obviously, the more you resect, the more risk you run of there being kind of secondary effects and lingering deficits from the surgery. So those are the ones we try to do the most. And then those that aren't really candidates for those, then that's when we do the neuromodulation, which is the RNS, the DBS, VNS. It's really common, especially because it was one of the older ones. And for generalized epilepsy, it's still what the FDA approved option. You still see it. I think nowadays, though, with the RNS and the DBS, for most patients, they're getting the workup done to make sure they're not candidates for that over VNS. And then if they aren't candidates for either one of those options, VNS can sometimes is still a choice. And especially for patients, there's a lot of patients that will tell you, and you can't convince them. They're not going to do any surgery. You're not going inside their brain. You're not touching their brain. And then the VNS is an option that you still have. Which is another palliative option. So that's something to consider. But most of these patients now, when they're coming into us, we're really making sure, are you a candidate for surgery with the phase 1 and then the phase 2? And if not, then are you a candidate for one of these neuromodulation? And the RNS does need pretty extensive workup. It does need a lot of times a phase 2, because the DBS, you're putting it kind of, you have an idea of where the seizures are coming from, you put it in the anterior nucleus of the thalamus. If you're doing FDA approved, you don't really need to know exactly where the seizure is coming from. The RNS, since it's a cortical lead, you have to be exact where you're putting this lead at, because if it's not at the actual epileptic foci, then it's not doing anything, because it actually has to pick up the seizure, and then kind of from that feedback, it's going to send an impulse, and which again is one of the really nice things about it too, though, because a lot of times it's hard to really determine for some of these patients, do they have bilateral epilepsy? Do they have unilateral epilepsy, especially in some of these temporal lobe epilepsies? And it takes sometimes months to really determine this. And when we do our EMU admissions, it's a week maybe. So if you're able to put the leads in the bilateral temporal lobes to kind of see where are these seizures really coming from, there's a lot of patients that sometimes you're able to say, oh, I thought this person had unilateral temporal lobe epilepsy, but actually the RNS is now picking up very rare seizures from the other side. So you actually able to kind of lateralize sometimes with these patients, or sometimes you think it's both sides. And then when you actually do the RNS, you see that, no, they're actually only coming from one side. And then you can do a resection on that side. You can actually bring them back, do a resection or an ablation, and then you can give that person seizure freedom.
Right. And just for information only, the reason why FDA does not approve the two foci is because of what you just explained, because we're not necessarily 100% sure that the actual foci is also located in the contralateral area.
So the reason that it's FDA approved for two foci is because it's only two leads. So technically, you're only the two leads in the two cortical foci, because it's not FDA approved for putting them in the thalamus either. That's something that you see a lot now. It's FDA, like, it's off-label use, but technically you only have the two leads, so you only have two leads to put in two foci. If there is 3 leads or 4 leads, obviously you could go more, but with the 2 leads, you're limited only to 2 areas.
Got it. Okay, one last question, because this is really fascinating, Dr. Tornes. You did talk about briefly also about the deep brain stimulation, and you did actually reflect on the fact that 75% of reduction in seizure thanks to this particular method. Do you still put the patient on a medication regimen even though you perform these procedures?
Yeah, so for most of these patients, they're still staying on their medications for the RNS, the DBS. For most of the neuromodulation, you're still sticking them on the medications, and maybe sometimes you can reduce the medications if possible, especially the patients having a lot of side effects. But the thing is, you're not obtaining seizure freedom with these. So they're still having seizures for the most part, most of these patients. So you don't really want to decrease the medications if they're still having seizures. The ones that you can really move off the actual medications are the surgeries, which is why they're still the gold standard. And even why, as you saw, one of the kind of the International League Against Epilepsy had recommended for evaluation was patients that have no seizures whatsoever, which I'm sure a lot of people are super hesitant, including the patient. If you have no seizures, you're on one medication, you feel completely fine, but you have lesional epilepsy where there's a very clear lesion and you know the epilepsy is coming from there and you can easily resect it, you should refer that person to surgery, because you could possibly take them off that one medication that they're on and they could be seizure free. So the surgeries are more the ones that we see that we can actually do reductions on medications. Sometimes that you can't reduce them all or take them completely off. But for neuromodulation, for the most part, they're usually on the medications. And sometimes, since you're not seizure free, you can still even add more medications afterwards.
Yeah. As I said initially, this is absolutely fascinating. And I think that the rest of the audience concurs with me. We can have you the entire afternoon discussing this particular topic, but we want to be considerate to you. The field of neurology and neurosurgery is evolving in leaps and bounds, and we're really consistently being fascinated by the amount of work and dedication that you guys put We're really thrilled to have you in our team, Dr. Tornes. Dr. Tornes, for those of you that do not know, he joined Baptist not long ago, and he is one of our fundamental pillars in treating this particular disease, and we're thrilled to have you. Dr. Tornes, we're going to let you go. And with that, I want to thank you on behalf of our entire international team for the incredible presentation and for making yourself available for us and for our audience. And to all of you that participated today, thank you. Continue to please forwarding your questions to our team, and we will make sure that Dr. Tornes receives them for him to comment on. Or if you're a patient or you know someone that requires assistance with seizures or epilepsy, please let us know. Our Movement Disorder Center will be happy to accommodate them for a consultation. Send us an email at BHIWebinars@baptisthealth.net. That is BHIWebinars@baptisthealth.net. We will be happy to assist you with that. We look forward to seeing you all in our next Neuroscience lecture series, which is scheduled for Wednesday, April 24th, 2024, of course. Thank you again, and have a wonderful, wonderful rest of the week. Thank you, Dr. Tornes. Have a great day.
Thank you so much for having me.
Our pleasure.
Bye.